Thank you, Dr. Bright. It's a great honor to be a part of this panel. I hope you are energized. That was a great presentation, Dr. Jones. I just want to thank the webcast planning committee. Having been now a part of that committee, it's easy to see what a tremendous effort is put into convening an event like this, and so I'm very grateful to be a part of this panel. I'd also like to recognize many of the speakers in the past who have addressed issues focusing on American Indian health, and hope that I am up to the task of addressing this issue similar to what has been presented in the past. I'm grateful for the opportunity that the committee sees the value in including a discussion on American Indian health issues as a part of this webcast. I'd also like to thank my host at the UNC American Indian Center, Amy Locklear-Hertel, Brandy Brooks, and Randy Bird. Just have been very generous and gracious to me in my stay here, and I'm very excited to see what the American Indian Center has in store. And if you have not visited the center, I would encourage you to do that. And I'd also like to pay homage to the American Indian people of North Carolina, who are represented by 8 recognized tribes, both at the federal and state level, and also the American Indian people who live here who are not part of the 8 recognized tribes. And I'd also like to thank you, the audience. It's very encouraging to us as a panel to see a group of people like you and the people across the world who are interested in these issues of health disparities and health equity, and it gives us hope in the work that we do that there is a consistent pattern that will be utilized to address a lot of these issues that Dr. Jones spoke about. So I have a fairly long title to my presentation, and that is on purpose, because I want to try to bring your attention to several words and phrases that I have as a part of my title. And so the title is Diabetes Among American Indians, a case study in moving from health disparities to health equity. And it's great that Dr. Jones has really set the stage here for a lot of what I'm going to be talking about in my presentation. And interestingly enough, the first word that I'm going to draw your attention to is the word among. And I'm kind of drawing from a book entitled Diabetes Among the Pima by Dr. Carolyn Smith Morris, who's a professor at Southern Methodist University. Dr. Smith Morris did a in-depth ethnographic study of the Pima people of southern and central Arizona. And in the study, the Pima Indian people have the highest prevalence rate of diabetes of any other people group in the world. And in this ethnographic study that Dr. Smith Morris did in the Pima population, she starts this very fascinating book by talking about the pervasiveness of diabetes in the Pima peoples. And they make an analogy to the Pima folklore of the Ho'uk, which is a predatory witch that was believed to come around and suck the life out of Pima children. And that is the feeling that the Pima people have about diabetes, is that it's so pervasive, it's so destructive to the people there in Pima country that it is like that it is sucking the life out of their people. And so I'd really encourage you, if you're interested in this topic, to read this book, and also read in the bottom right-hand corner. There's a free publication on the National Institutes of Diabetes and Digestive and Kidney Diseases website called The Pima Indians Pathfinders for Health. And it talks about the trajectory of the U.S. government's role in, first of all, discovering these tremendously high rates of diabetes in the Pima people, but then the work that has gone on there since the mid-1960s in trying to address this issue. So I want to also now, and you've had a little bit of introduction into these issues, so I want to draw your attention to the phrase health disparities. And I'll draw from a definition of health disparities that has been adopted by the National Institutes of Health, and that is that the health disparities are differences in the incidence, the prevalence, the mortality and burden of diseases and other adverse health conditions that exist among specific population groups in the United States. And so we can look at a report like this report by Dr. Donald Barr or other reports that are available that show graphs and statistics. I'm an epidemiologist, so I love graphs and I love bar charts and line graphs and all that type of thing. But when we talk about these health disparities, we are really talking about these differences in these measures, these public health measures that we use in the occurrence or the impact of these diseases in these populations. And we could really spend pretty much all of our time on this one particular slide. We know that for the more than 5 million American Indian and Alaska Natives in the United States, that there is a tremendous disparity of diabetes. American Indians are at least 2.2 times, this is nationally, at least 2.2 times more likely to develop diabetes in their lifetime compared to non-Hispanic whites. And that rate varies actually pretty dramatically depending on what American Indian tribe you're looking at. And again, keep in mind, we're talking about 5 million American Indians and Alaska Natives, but we're talking about over 560 federally recognized tribes and hundreds of other state-recognized tribes across the country. We know that the diabetes death rate for American Indians is 3 times higher compared to the U.S. general population. And then one of the most difficult physical circumstances of diabetes, that being kidney failure, is very, very common in American Indians. And we know that on average, the rate of diabetes-related kidney failure is 3.5 times more likely to occur in American Indians with diabetes compared to the general population. Now, here in North Carolina, we do have a fairly sizable American Indian population. I'm an enrolled member of the Lumbee tribe, and our homeland is located down in the southeastern part of the state. I know you probably couldn't tell from my accent that I'm from North Carolina, but I am. But then we also have, actually there are American Indians living in all 100 counties of our state, and there is also a large concentration of American Indians, the federally recognized tribe in western North Carolina, the Eastern Band of Cherokee Indians, but also the other shaded counties are the urban Indian centers across the state. And unfortunately, we here in North Carolina are not immune to the devastation of diabetes in American Indian people. And these are data that are taken from the Eastern Band of Cherokee Indian population. And you can see that both Eastern Band men and women have extremely high rates of diabetes compared to North Carolina citizens as a whole, particularly for Eastern Band men, where you can see that the rates are as much as 5 times higher for Eastern Band men compared to North Carolina men. And interestingly, we're starting to see, particularly for type 2 diabetes, the more common form of diabetes, we're starting to see type 2 diabetes being diagnosed at younger and younger age groups. And data from the Search for Diabetes and Youth study, which I'm involved in at Wake Forest, we see a very unusual pattern of diabetes depending on what racial and ethnic group that we look at. So if we look at the pattern of diabetes among type 1 diabetes across the 5 racial and ethnic groups, you can see that the rate is highest for non-Hispanic whites and quite low for American Indians. But the almost exact opposite is true for type 2 diabetes, the more common form of diabetes, where the rates of diabetes among American Indian youth is extremely high. And actually, a lot of what we know about type 2 diabetes in kids comes from the early work from the PEMA population back in the early 1970s and 1980s. It was almost unheard of to think about kids having type 2 diabetes, and now it's very common, and a lot of the early work that went on comes from American Indian populations. So when we look at this issue, we look at, again, looking at these graphs and looking at these models and saying, yes, there's a gap there. Well, why does that gap exist? So we know from the definition of health disparities that there is a gap that exists, but we don't exactly know why. And if we were to take sort of a traditional biomedical model approach to looking at this and trying to answer these questions, we might say, well, it's because American Indian people have poor diets, or that it's because American Indian people are not physically active or not as physically active as other people, or that it's some defective gene that is causing this disparity, or that it's because American Indian people don't access health care, or they don't utilize the health care that's available to them. And that would be a very myopic view of looking at this. And so why don't we take a step back and look at another phrase from my title and look at the concept of health equity. And Dr. Jones did a very eloquent job of defining health equity. And so I'll just reiterate what she said and say that health equity is the attainment of the highest level of health for all people. And achieving that health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and health disparities. And I draw that from the recently developed U.S. Health and Human Services National Partnership for Action to eliminate health disparities. So that's a more comprehensive way of looking at this issue, not just to say that there's a gap, but why does that gap exist? And so when we put the health equity lens on, then we might say, so American Indians have higher rates of diabetes. We also know that there's a very strong linkage between diabetes and obesity. Well, maybe American Indians have higher rates of diabetes and obesity. They have poor diets because they have higher rates of poverty. And poverty not only does not allow you to afford the healthy foods that you need to eat, but it also provides opportunities to eat unhealthy foods. And so we can look at it through that model and say that it's a direct linkage to poverty. We know that wherever it's been studied across the world, there's a very strong relationship between poverty and risk for developing diabetes and obesity. We could also look at this as being a problem related to inappropriately applied local, state, and federal policies. So if we take a step back and look at the Pima population, they went from essentially having no diabetes in their community to having one of the highest rates of diabetes in the world. How does that happen? And that happened in about 100 years. How does that happen? Well, what happened, if you go back and read what happened in the Pima communities, is that the Pima peoples were farmers and lived off of foods that were very healthy, and because of policies that were put into place, they lost their water rights, and so they were no longer able to grow the foods that they needed to grow. And so they lost that ability to eat healthy. Then the other thing that happened was that commodity foods were brought into the reservation, and we know that commodity foods are very high in calories, very high in fat, very high in sugars. And so you had this double-edged sword of people losing their ability to prepare healthy foods for themselves, but also being provided foods that were not healthy to them. So this was a double-edged misappropriation or a misallocation of policies that influenced these people dramatically. Racism. We know that there are biological effects associated with racism. We know that it is also the case that there's a linkage with our biological systems that influence hypertension, glucose management. All of those areas can be influenced by our exposure to racism. We know, too, that in many of the Indian communities where diabetes is so common, we see this hopelessness and fatalism. You will hear the phrase, well, I don't have diabetes yet, as if it's going to eventually happen. And so when you have that situation occurring, it's just very difficult to break through that barrier. And then finally, there's actually a lot of research going on in the issue related to historical trauma, and I want to use a definition by Maria Yellowhorse Braveheart, where she defines historical trauma as the cumulative emotional and psychological wounding across generations, including the lifespan, which emanates from massive group trauma. And we know that the disruption, the robbing, if you will, of the traditional practices and culture of Indian people has had detrimental effects. And to believe that that only affected one generation, I think, is very misguided. And so we can look at all of these issues and look at this health disparity that exists and say, if we're going to apply a health equity model to this, then we got to think very broadly about how to address this issue. And this is actually addressed very eloquently in the Unnatural Causes video series. I don't know if any of you have seen this, but one of the episodes of the Unnatural Causes series is called Bad Sugar, and it addresses the issues surrounding diabetes in American Indian populations and how policies that have been put into place have led to these dramatic increases in diabetes. And the man in the bottom left corner is Dr. Donald Warney, who is an Oglala Lakota Sioux, who is a physician as well as a traditional healer. And he is featured in the Unnatural Causes videos that you can, some of which you can watch online, where he speaks very eloquently about some of these issues. So when we talk about diabetes prevention and control in American Indian communities, and clearly, I mean, diabetes is a very complex disease. It's something that you have to have a very strong understanding of. And so education is a very important component to helping not only the person with diabetes, but the person that's treating that patient with diabetes. But that education has to be incorporated within a framework that's culturally adaptable to that particular community. It also has to have a message of empowerment. I mentioned that whole issue of hopelessness earlier. We need to reframe that to say, you know, how do we empower people to think that they can not only control their diabetes, but in cases where they are at risk, that they can actually prevent the occurrence of this condition. We also need to think about the allocation of resources. How are our resources allocated in such a way to where we get the most bang for our buck? But also, particularly in American Indian communities, it's very important to have a holistic orientation to consider mind, body, and spirit, and how living a healthy life can affect all three of those. And part of what we have now, the challenge we have, is trying to take the message of the diabetes prevention program. This was a national study that was conducted in the early 2000s, which showed that diabetes can be prevented pretty dramatically, a 58% reduction with intensive lifestyle modification that influences diet and physical activity. So that's a very positive message. And the National Diabetes Education Program is very actively engaged in taking the messages of the diabetes prevention program and other programs and other research studies and taking that and adapting it to the communities that are most affected by these conditions. I am a member of the American Indian Alaska Native Stakeholders Group of the National Diabetes Education Program, and we have developed a lot of initiatives where we are trying to get the message out, the positive messages out about diabetes prevention and control. These are two campaigns that we came up with, the Power to Prevent campaign and the Move It campaign. I particularly like the Move It campaign because it shows these very vibrant youth who are out exercising and enjoying the outdoors. And so these are two messages that we have developed as a part of the NDEP campaign focusing on diabetes prevention. Another area which doesn't get a lot of attention is that there is a very strong linkage between diabetes and depression. And actually there was a study released just today from the journal Diabetes Care showing that people that have both diabetes and depression are twice as likely to to die early compared to people who have one or the other. And so we developed, as part of the NDEP, we developed a toolkit for healthcare providers to try to help them to talk about some of these issues in the clinical setting. And what I really like about our banner there is that we had two drums. We have a drum that is recognizing American Indian populations on the left, and then the drum on the right is more representative of the Alaska Native communities. So we were trying to be as inclusive as we possibly could. Federal agencies are adopting these messages as well, like the American Diabetes Association has the Awakening the Spirit campaign. The book on the right is actually part of a series of books, children's books, focused on education around healthy eating and physical activity, written by Georgia Perez and distributed by the Centers for Disease Control and Prevention. A really neat series of books, and I would encourage you to go on the CDC website and order those books if you're interested. But then also, you know, oral tradition is very important in Indian communities, and so a lot of communities now are developing what we call diabetes talking circles. And diabetes talking circles would look a lot different than your traditional diabetes support groups. Diabetes talking circle there may be some discussion about issues that maybe aren't necessarily directly related to diabetes, but it's something that allows for that empowerment that I talked about earlier in trying to address these issues. And then a wonderful book that I would encourage you to read that is distributed by the Indian Health Service called Using Our Wit and Wisdom to Live Well with Diabetes by Barbara Mora. It's just a wonderful book where she talks about her journey of going from the fear of being diagnosed with diabetes and what that all entailed to then feeling empowered and feeling like she could overcome some of the challenges that living with diabetes would present her. Also want to give a notice to a couple of programs here in North Carolina. I know you can't really read this very well, but the Cherokee Choices Diabetes Prevention Program is really it's a community-based initiative focusing on diabetes prevention. I showed you the data from Cherokee earlier. Michelle Obama recently acknowledged the work of the Cherokee Choices Program. And also, I don't have a picture of it, but the Healthy Native North Carolina program, which is working with 7 of the 8 tribes in North Carolina, focusing as kind of a grassroots initiative focused on healthy eating in these communities. So, and there has been success when we take some of these approaches. I mentioned the allocation of resources. There is a program that is where Congress allocates funds through the SDPI, the Special Programs for Diabetes in Indians. They have allocated funds specifically for diabetes prevention and control in Indian country, and this analysis showed that when those funds are allocated to the communities and the communities have a say in how those funds are utilized, then it has some significant impacts. And so this analysis from 2005 showed that there has been significant reductions in risk factors associated with diabetes complications that would have significant cost impact. And so we have to have the ability to think about prevention as a way to address some of these issues. And the SDPI money is one of those issues that keeps coming up as being under threat of reduction, but it is still in place, and very grateful to that. So in summary, diabetes disparities clearly exist. These disparities are multifaceted, but the solutions to these challenges should also be multifaceted and really requires a concerted effort for us to understand and address these issues. So with that, I thank you very much.